Thank you, Harley, and thank you all for joining us today. This is the first of the particular series about local leaders, although price talks have been going on for a while, and I appreciate our staff and our school for really doing everything we can during these difficult times, so to speak, and in trying to engage our community and to be who we are as a school in an attempt to be transformational and impactful in our communities. And for us as academics and practitioners, those of us who do both, this is important because in the practice in particular, we make decisions on the basis of information and data, and policy is not necessarily made on the basis of 100%. It's made on the basis of the overall good. And for us at the local level, especially to make policies that are for the overall good, we need extremely reliable information that we can use in order to make that policy. So today it's all about that. It's all about getting information about our communities, especially on a topic that is extremely important today. And I'm delighted to have my colleague and friend, Neeraj Sood, who is with us today to present a topic that is so important. Neeraj, to his credit, was one of the first ones in the nation to recognize the importance of testing and understand, of course, the importance of immunity ultimately. And with all accounts, there is a lot of literature and science to show that it's not only about the vaccine or medication, but also our immunity that actually we develop over time. So I am looking forward to seeing some of the data that Neeraj with his colleagues are collecting in the County of Los Angeles in particular, and throughout our region. And of course, for our local leaders who are online, to be armed with very important and relevant information to make the decisions that they need to make. One size fits all is no longer valid. Yes, we were very attuned to the important decisions that we've made several months ago in putting people making sure that we protect most. Today, however, it's a dynamic position that we're in, and things are moving. As you can see, the state and the county is looking to open up and do various things, but we do those things safely with information. And I'm so happy that Neeraj is here to share his information and his data with us so that those of us who are in the front lines and making decisions can make those decisions in a more informed way. With that, Neeraj, I'm going to turn to you and ask that you, of course, you start your presentation. I see you have a PowerPoint presentation, so looking forward to hearing from you.
Thank you for that introduction, Frank, and thank you for giving me this opportunity to talk to our local leaders. There are two goals of the talk. One is I want to kind of tell you the research we've been doing over the last 2 months or so. And the second is I want to kind of talk about what are the policy implications of the research we've done, and just more generally some thoughts on how do we think about public policy when it comes to COVID-19. So my journey doing this research started on March 15th, which is about 2 months ago, when I published an op-ed in the Wall Street Journal called "It's Dangerous to Test Only the Sick." So let me explain what I was trying to, what point I was trying to make. So traditionally, when you think about testing, you are thinking about diagnosing an individual. So someone who's sick or who has symptoms comes to a doctor's office. The doctor doesn't know what is the underlying disease. So you do a diagnostic test to figure out, is it a bacterial disease? Is it a virus? And then based on that, you try to figure out what is the appropriate treatment for the disease. So the primary or the traditional role of testing has been diagnosis and then tailoring treatment to that diagnosis. But for a new disease like COVID, we don't really have a good treatment. So in that sense, just testing sick individuals to figure out whether or not they have COVID doesn't influence in a big way the clinical decisions you make on how to treat that person. You're in some sense right now treating symptoms rather than the underlying disease. So the second function of testing could be to avert secondary infections, especially for an infectious disease. So the idea would be if someone is symptomatic, you want to test them because you want to figure out whether they have COVID or not. And if they have COVID, you want to give them instructions to stay at home, self-isolate themselves, and then figure out who else they came in contact with and ask those individuals to quarantine themselves. So again, here, testing only the sick would make sense if everyone who had COVID was symptomatic, or if most people who had COVID were symptomatic. But that's also not the case. We now know that there is a lot of asymptomatic infection. The third purpose of testing could be, especially for a new disease like COVID, is to understand the disease, is to understand, what the mortality of the disease is. It's to understand how contagious the disease is. So for example, if you want to understand who's going to win the next election for being the mayor of your city, how are you going to figure that out? Are you only going to poll Republicans to figure out who's going to be the next mayor in your town? Or are you only going to poll Democrats to figure out who's going to be the next mayor in your town? Or are you going to take a random sample of adults in your town and then figure out, which of these adults are going to vote for the next candidate? So that's the same logic with testing. If you really want to understand a disease, you cannot just focus on the sick population. You cannot just focus on the asymptomatic population. What you need to do is test a random sample of the population and then learn from that random sample how deadly this disease is and how contagious this disease is. So that was basically what I advocated for on March 15th, that look, we should be doing random sampling of the population to figure out how many people have actually been infected with this disease. And then based on that, figure out how deadly this disease is or how quickly it is spreading through the community. So after we published that op-ed, now we've done a large study in Santa Clara County, where we tested a large community sample of 3,000 individuals. Then we followed that with another study in Los Angeles County, which I led in collaboration with the Los Angeles County Public Health Department. We actually just finished the second round of testing last weekend. So now we've done 2 rounds of testing in Los Angeles County. We worked with Major League Baseball, and now we've tested more than 5,000 Major League Baseball employees in 25 different cities across the US. We're planning studies of first responders and children. And I'm helping numerous counties, cities, and other jurisdictions who basically want to learn from our experience and do their own seroprevalence studies. So that's a lot of activity in the last 2 months. And I would be happy to help any of you do such studies if you want to conduct these studies in your city or in your town. So you can either reach out to Harley or Frank, and they can put you in touch with me. So what have we learned from these studies so far? So the first lesson is that the number of confirmed cases of COVID-19 is a poor proxy for the true extent of the infection. So what we found out in LA was that the true extent of the infection was about 50 times higher than the number of confirmed cases. That's we reached a very similar conclusion in Santa Clara. Now there have been several other seroprevalence studies, and they've all kind of found very similar results. So when you just look at the number of confirmed cases being reported by your public health department, that doesn't capture the true extent of the infection. The number of actual people who've had COVID might be several times larger than what is being reported by our public health department. And these results are, robust to accounting for the accuracy of the test. I can answer questions about the accuracy of the test. And non-response bias is, again, a statistical term for how we sample people in these studies. The second thing these studies show is that there are, several or a significant, like a majority of individuals who are infected with COVID, who we identify as having COVID, do not seem to have symptoms that are consistent with COVID-19, which would be fever with a cough, fever with shortness of breath, loss of sense of smell or taste. So this says that there is a lot of asymptomatic disease where people have been infected and they didn't have these classical symptoms, so they don't even know that they had a COVID infection. We also found out that if you really want a marker, the best predictor of having a COVID infection among all the symptoms we looked at seems to be the loss of sense of smell or taste. So that could be used potentially as a surveillance, as a cheap surveillance tool to figure out how many people in your community might have had a COVID infection. And finally, these infection rates, there's no one infection rate. Infection rates vary by geography, they vary based on income, and they vary based on race, ethnicity, the neighborhoods you live in. So if you really want to understand what's happening in your community, you need to do this study in your community. You cannot take the results from the LA study and extrapolate it to what's happening in your community. What's happening in your community might be very different than LA or Santa Clara or the other places that are conducting these studies. So now, what do these results mean for policy? So the first thing is, it means that the hospitalization rate and the mortality rate of COVID is going to be much lower than what was previously estimated based on the number of confirmed cases. So to just kind of give you an example, suppose there is a place with 100 deaths and you have 10,000 people who are confirmed to have COVID. So this would say that the mortality rate is 100 divided by 10,000, which is 1%. So that says for every 100 confirmed cases of COVID, you get one person dying. So what our studies are saying is, look, if there are 10,000 confirmed cases of COVID, the true number of cases of COVID is much higher. It could be 50 times higher. So therefore, the true mortality is going to be much lower, because now instead of having 100 deaths among 10,000 cases, you have 100 deaths among 500,000 cases. And that changes how you think about this disease. That changes how you think what would happen to your healthcare system as you get more and more infections in your community. So the first lesson is, look, we should be using these studies, estimating mortality rate and hospitalization rate based on these studies, and then updating our models. But basically what it would say is that the chance of the virus overwhelming the healthcare system is still there, but it's going to be lower than what we initially assumed or forecasted based just on the confirmed cases. The second thing, all of you have, I'm sure, heard about contact tracing and testing. Well, what these studies say is, look, first, there is a lot more infection than we thought there was. So if you want to do contact tracing, which is testing people who are potentially infected and then testing all their contacts and their contacts, that's going to be much more challenging, because it's easier to test 1,000 people versus 50,000 people in your community who might have COVID. So as the infection spreads in the community, contact tracing becomes just more and more challenging. And the second thing is the strategy where you were testing people who were sick or who had symptoms to identify infections and isolate them. Well, that's not going to be very effective if a lot of the people who have COVID are actually asymptomatic. So both these results, which says, look, the true extent of the infection is larger and there are asymptomatic cases, says contact tracing is going to be much more difficult and challenging than we thought it would be. And finally, what our study showed was, for example, in Los Angeles County, we found about 4% of the population had been infected with COVID. A lot of scientists believe, based on how contagious COVID is, that we will hit herd immunity when either 60% of the population has been vaccinated and has, as a result, some immunity from this disease, or if 60% of the population has been infected and as a result of that infection has some immunity from the disease. So if we are at 4% right now and herd immunity is achieved at 60%, we are very far away from reaching that level. So what that means is we cannot be making policy decisions based on what's happening over the next 2 weeks or the next 2 months. We need to be making policy decisions about what's going to happen till the time we have a vaccine and we can vaccinate everyone, which might be 18 months or much longer, because we really don't know when we're going to get a vaccine. If that vaccine is really going to be effective, would we have the capacity to quickly vaccinate 60% of the population? So whatever we do, we cannot make decisions based on, oh, this is working now, but not have a long-term plan. We need to have a long-term plan. So whenever we make a decision and we evaluate, is this a good policy decision or not, we should be looking at least 18 months to 2 years down the line. So just some other thoughts on public policy. So the first thing is that social distancing or lockdowns or whatever you want to call them, they do not change the number of infections over a long time horizon. But what they do is they change the timing of the infections. So to just give you an example, suppose there is a town that does extremely strict social distancing. So what will happen is for the next 6 months, they're going to do extremely strict social distancing, and the number of people with antibodies or the number of people who are infected is going to be very small. It's going to be 2 to 3%. But then after 6 months, when they give up on social distancing, we still don't have a vaccine and we haven't hit herd immunity. So what will happen is the other remaining 58% of the population will get infected after 6 months. And because we still don't have a vaccine, the vaccine is still a year away. So you're going to get the remaining people getting infected till the time we hit herd immunity. You take another county or another city which does, say, moderate social distancing. So what will happen is they will see many more infections over the short run because they did moderate social distancing. So maybe over the next 6 months, they will hit a seroprevalence of 20 to 30%. But ultimately, they're all going to hit 60% or whatever is the level of prevalence needed to hit herd immunity. So what you're doing with social distancing is you're changing the peak of the infection. That's why they call it flattening the curve. But you're not changing the area under the curve or the total number of infections. So once we understand that, then we can start to evaluate why would we want to do social distancing or what are the benefits and costs. So the big benefit of social distancing is it reduces the probability of overwhelming the healthcare system. So this is what is called flattening the curve. You want a smaller peak. So it's not changing the total number of infections, but it's making sure that everyone doesn't get infected over the next month and overwhelm the healthcare system. And if you overwhelm the healthcare system, you're going to have more people die. Because if people can be treated in hospitals, you can save their lives. If all the hospitals are full and you cannot treat them, that is going to result in higher COVID mortality. So I think that's the big benefit of social distancing. But that has to be evaluated against the cost of social distancing, which is it might increase the second peak or second wave of the infection. So for example, if you do social distancing now and you have no one infected with COVID and you give up 6 months later, well, 6 months later, you have a depleted healthcare system and you haven't come anywhere close to herd immunity. Your entire population is susceptible. So now your second wave of infection, when you give up on social distancing, is going to have a much higher peak because you didn't have enough people who got infected prior. The second thing is social distancing. You know, we are all social animals or social beings. So being stuck at home, not being able to meet people, creates a lot of stress and anxiety. It reduces our quality of life, and it leads to a lot of social problems. It might lead to an increase in homelessness. It might lead to changes in, drug abuse and so on. Social distancing can also affect, have economic implications, not only for citizens, but for businesses, nonprofits, and governments. It can also influence health because now there are a lot of people who have chronic diseases or who have symptoms of, say, heart disease, but they don't want to go see their doctor because we're not allowing elective surgeries and people are scared. So this is, a lot of experts believe this might have adverse health effects a few months down the line because people are not getting the primary care they need right now. And last but not the least, we all believe a lot in, education for children is compulsory for a reason because it provides a lot of value. It builds human capital. And with stringent social distancing, we have a lot of children who are out of school, and children in lower income families or children in families with where parents are not, don't have a high school degree or a college degree are going to be affected much more than children from more well-to-do families. So what this says is, if you're thinking about what is the level or the optimal level of social distancing, you want to look at both the benefits and the costs. You cannot just look at the short-term benefits in terms of COVID mortality. You need to look at longer term, and you need to look at all the benefits and costs. So we need to kind of go beyond COVID-related outcomes if we really want to think about public policy here. And finally, there are many other options if other than social distancing that you would want to think about. So you should not just think about social distancing. You might want to think about, so for example, if your primary goal is you don't want to overwhelm the healthcare system, well, there are two ways to tackle this. One is to reduce the demand, which is what social distancing does, is it keeps people at home so that there are no infections and people don't end up in the hospital. Well, the flip side is you can also increase the supply. So you can have many more hospital beds or many more doctors with appropriate PPE to treat patients so that the system doesn't get overwhelmed. It has higher capacity. And then you can weigh the pros and cons of these two policy options. Similarly, instead of saying everyone stay at home, you might want to do risk segmentation, which is, we know, for example, 50% of the deaths in LA County and in a lot of other cities and regions are in nursing homes. So you got to evaluate what is the best strategy for preventing those deaths in nursing homes. Is it that people stay at home? Or is it infection control in nursing homes? Is it additional testing in nursing homes? What should we be doing here? So that's what risk segmentation means, is not think about a one-size-fits-all policy, but think about different risks for different populations and then try to understand what to do. But I think the bottom line is there is no easy solution here. I cannot pick one policy and say, I'm very sure you should implement this. All I can say is any policy you implement, you will do it under uncertainty. We will not have the answers, but think about a variety of policy options. Think about all the benefits and costs. Don't just focus on COVID-related mortality, and think about a longer time horizon. Don't say this is working for the next 2 months, so it's great. We really need to think this disease is going to be with us for a long, long time. So when you think about policy options, you got to think about something that's feasible in the long run. And I'll stop there and take any questions you have. Thank you.
First one is, why are the survey results robust even if test specificity is poor, especially if the attack rate is relatively low impact?
Sure. So the test kits we used, we've now evaluated them using 16 different samples with more than 3,000 blood samples. So, and based on looking at the results from all these 3,000 blood samples, the test specificity is actually 99.5%, which means that for every 200 people you test, you just get one false positive result. And when we do our analysis, we account for that possibility of false positives. So in some sense, we actually know that this test is highly specific, and that's why we can use it even in a low prevalence environment.
Thank you, Neeraj. Another question, do you recommend that everyone get tested for COVID even if an individual does not have any symptoms?
So it depends on whether you want to make a personal decision or a public policy decision, and what type of test you want to use to get tested. So if you want to make a personal decision about testing, then you should decide what is best for you. Even if you are asymptomatic, if you use a traditional test, which is called a PCR test, that tests for the virus itself or genetic material from the virus. So if you do a PCR test, it will tell you whether or not you are shedding the virus. If you do an antibody test, it will tell you whether or not you've been infected at any time during the past. And that's useful. So people think that getting infected gives you some immunity. So if you want to know whether you have some potential immunity, then getting an antibody test would be useful. But it doesn't, the science hasn't progressed enough to know how long this immunity will last and how strong this immunity is. So does it mean that you have no risk of reinfection, or does it mean you have 50% risk of reinfection? It's very difficult to figure that out. And from a public policy perspective, you would want to test both symptomatic and asymptomatic people if you're worried about stalling the spread of the disease, because we know a lot of people who have the disease are asymptomatic. So you have to have some testing strategy where you're trying to get at the asymptomatic population.
Okay, the next question is, how long should LA County remain in lockdown?
Well, that's, as I said, all I can say, I don't know the answer to that. But what I would say is, when LA County or any county or anyone making a decision about lockdown versus not should look at all the benefits of a lockdown, but also look at all the costs of a lockdown and have a long-term time horizon. Don't think about a lockdown and evaluate outcomes over the next 2 months. Think about a lockdown, all the benefits and costs, and look at least outcomes over the next 2 years. And then you got to figure out what's the best decision for your county and for your own jurisdiction.
Okay, and the next question is, how can we then obtain herd immunity if we have strict expectations with lockdowns and social distancing? Could the virus mutate more so then when it has some staying home and following social distancing, which could also be argued aids in immunocompromised health and proper hygienic practices while others are not?
So that, if you have a strict lockdown, you're going to take longer to achieve herd immunity. And in some sense, that is one of the costs of a strict lockdown. So if you do a strict lockdown for a few months and then you give up, your second wave of infection is going to have a higher peak because there are more susceptible individuals in the population, versus if you do a moderate social distancing, don't still overwhelm your healthcare system, but there are more people who've been infected and have had some sort of immunity. Then your second wave is going to have a flatter peak because already some fraction of the population has been infected. So I think there is this trade-off between managing infections right now versus managing infections during a potential second wave.
Okay, then this next question is from our Facebook live stream. What type of testing is the one that the city of LA has available to the LA residents?
So the city of LA has what is called PCR testing available to LA residents. So that's the kind of testing that tests for an active infection. The testing we did, part of our study, was called antibody testing. That's testing for antibodies which could be a result of past infection.
Next question, do you see value in local governments implementing tracing through neighborhood associations as opposed to methodological tracing by healthcare professionals?
I think it just depends on the details on how you implement it. Right now, a lot of people are thinking about digital tracing apps, which use cell phones and the Bluetooth on your cell phones to figure out who you've been in close contact with. So I think there are a variety of different options. We're still kind of figuring out how to implement this. So I think people just need to experiment and figure out how to implement this.
Okay, another question from our Facebook Live. What types of public policy could represent the interests of people who don't want to risk infection?
Well, everyone doesn't want to risk infection. So infection is going to affect, is going to have some adverse consequences. But all I'm saying is, when you think about public policy, you should not just think about the health effects of COVID and of a potential COVID infection. You should be thinking about the health effects of mass unemployment. You should be thinking about the health effects coming from stress and anxiety. You should be thinking about the health effects that might come from a depleted safety net system. And you should be thinking beyond health. You should be thinking about children's education. You should be thinking about a variety of things when making a public policy decision. I think public policy decisions just based on one cause of mortality are not going to be great decisions.
Okay, the next question. If I am tested and I'm clear, I may catch it the next day. So for someone asymptomatic without people at risk in my home or workplace, what is the value of a test as it just tells me the answer at one point in time?
That is true, that a test tells you. So if you're doing a PCR test, it just tells you right now whether you have an active infection or not. It doesn't tell you that you will never ever get an infection. So that's why the value of a PCR test is to identify people who are actively infected and then try to isolate them. But that becomes more difficult if there are a lot of people who are asymptomatic who are infected, because they don't even know that they're infected and therefore they're unlikely to get tested.
Next question, is Sweden achieving herd immunity?
So the studies that have been done in Sweden suggest a much higher prevalence of antibodies. So that suggests that they are closer to reaching herd immunity. So the estimates are that their prevalence of antibodies is around 20 to 30%, which is several folds higher than what we found in LA. So they are definitely closer to reaching potential herd immunity.
Okay, next question is, would you characterize the Los Angeles shelter-in-place order as a strict lockdown?
I think it is a strict lockdown. Yeah, I would characterize it as a strict lockdown.
Okay. All right, I'm going to turn it over to Frank, who has some questions as well.
Sure.
Well, actually, I want to have a conversation with Neeraj a little bit, and I think that we can expand this because you touched on a bunch of things, Neeraj, that is really, really helpful to our community of mayors and council members and to our Board of Supervisors, frankly,
Mhm.
because as you correctly point out, there is no one size fits all.
Yeah.
And I can tell you right now that in my community of the Palos Verdes Peninsula, 70,000 people living here, we have known 150 cases only. That's a
Mhm.
0.006% of the
Mhm.
population.
Mhm.
What should our local governments do in terms of dealing with this with their respective? You suggested one, which is contact us and we'll do a survey of your community.
Mhm.
How do we do that? Talk a little bit more about that, because we have a bunch of mayors and council members on the line right now
Mhm.
that would love to know what to do for their community. And if they do that, what happens with their borders? I mean, it's not like, they're going to erect walls.
Mhm.
People are going to
Mhm.
come in and go.
Yeah.
How does that affect that?
Mhm. So I think, so what we did was, so we can help people do these studies. We can't do the studies for themselves. We just have a limited bandwidth. But the idea would be, you take a sample of people in your community. So in, say, Frank, in your community, you take about 1,000 people and you do antibody testing on them to figure out how many or what fraction of them are antibody positive. So if your number of confirmed cases are right, then in 1,000 people, you should find no one being antibody positive, right? Because your prevalence is really low. It's 0.006%. So, or maybe you'll find 1 out of 1,000 people who are antibody positive. So if that's the case, that says your community has been protected from COVID. So now what you should be doing is actively, so now your contact tracing can actually work, because there's no one in your community who has COVID. So anytime you find someone who has any symptom or any exposure to anyone with COVID, you want to go test them right away. And then you want to isolate them. But if you find out 5,000 people in your community have COVID, it's going to be very difficult for you to now start tracing everyone and figuring out what's going on, right? So the value of these studies is to kind of get a sense of what stage of the epidemic are you in? Are you in the early stages? In the early stages, it's kind of like if you're cooking in your kitchen. If there's a little fire in your pan, you can douse it. But if your whole kitchen is on fire, you got to use some other strategy, right? So figuring out which stage of the epidemic you are in is going to help you figure out what policy actions to take. And then the second thing is, it will help you figure out, if suppose you find out 5% of your population has been infected with COVID, but no one has ended up in the hospital. So then it says, look, this is not as scary as we thought. That even with 5% of the population infected, no one has ended up in the hospital. We don't need to worry about this infection in the general population. Maybe we should be focusing really on the elderly, on the nursing homes, protecting them. But if you see a lot of people ending up suppose you find out only 50 people are infected and 5 of them ended up in the hospital, now this looks like a much more dangerous disease, because this says, as this spreads in your population, it's going to overwhelm your hospitals. It's going to exceed your hospital's capacity. So those are the decisions you have to make. And then, as I said, you have to look at, how is this affecting your city's finances? Is the right strategy here building more hospital capacity? Is the right strategy here taking care of nursing homes? What should you be doing? And there's still a lot of unanswered questions. For example, we really don't understand fully how many kids have been infected and what is the ability of kids to infect others. That's a key question when you're thinking about opening up a school, right? You want to understand how many kids have been infected, what are the implications of infections for kids, and can kids be effective carriers of the infection or not? So that would again require studies in your community. And, I think local communities can start, in some sense. Sometimes I feel local communities are more nimble than larger bureaucratic organizations, where the same study or the same question will take us 6 months to answer because we will be going through multiple hoops within an organization. But local communities can get together and say, look, I think this is important for our community, and we're going to figure out how to do this.
You know, there was a question earlier about at the neighborhood level, the tracing issue. To be honest, for a community like mine, for example, I said 150 people over the entire peninsula. Frankly, we know that we have a bunch of neighborhoods. It sounds to me that we may be able to actually be able to trace these people through technology. Would you find that helpful?
I think so the other thing is that tracing works if everyone uses the same technology.
I see.
So if everyone is on the same app, right? So if I'm on a different app than you, and then even if I come in close contact with you, you will not know because you will not get the message, right? So you want, in some sense, everyone in your community to be on the same app. And then if you do some randomized testing in your community of all people who exhibit any symptoms, as well as some asymptomatic people, then you can say, okay, I have a good chance of catching early infections. And the moment I catch an early infection, everyone in my community would know because everyone is on the same app. And then I can do effective contact tracing, get them tested. So in that sense, it would require that coordination.
So next week, we're going to talk about, during these price talks, next week, we're going to tackle the issue of post-COVID financial crises, especially at the local government level. You know, that's my area of expertise and my discipline. And one of my former law partners is going to join me, who's a crises expert and Chapter 9 expert in debt adjustment for local governments. But I agree with you. We're going to see some of our, unfortunately, most vulnerable communities at the local level decimated as a result of some of the policy decisions we are making. So I want to kind of pivot to ask you about, first, there was an article, and I know I shared it with you. Some of our colleagues from MIT, for example, wrote a very important, I think, article about more targeted quarantining and sharing numbers, actually data about being more effective than an overall lockdown, which from what I'm hearing from you seems to be the message just as well, in a sense. As well as today in the Atlantic and the New York Times, there were a couple of articles, one from Harvard colleague of ours and one from Johns Hopkins colleague of ours, talking about the opening and talking about the exact topic of social distancing, where you're delaying the issue, not necessarily dealing with the policy of the issue. So talk about, in terms of those articles that you may have seen, and especially the MIT one, a little bit, and then maybe what advice do you have to our local communities, especially with vulnerable communities within themselves, like seniors, etc., that you can talk about?
Yes. So I think the most vulnerable population is seniors, especially seniors in nursing homes, because then you have a lot of seniors in kind of the same location. And so if you look at the mortality data, like 50% of the deaths in LA County are in nursing homes. So that says, look, the first priority should be to protect those nursing homes, right? So basically, everyone in that nursing home, so we need rapid testing for active infections. And now there are actually some new tests that were just FDA approved that can enable that rapid testing. So what you want is testing the nursing home population every 2 to 3 days for an active infection. Because you know, one active infection in the nursing home can spread quickly in the entire nursing home and can lead to huge mortality effects. So I think the first thing I would do is have very high frequency testing in nursing homes, have high frequency testing of anyone who's entering a nursing home should first get tested, get cleared. And I think just screening for temperature is not good enough, because as we've seen, that there are a lot of people who are positive who don't even know they're positive. They're not exhibiting any symptoms. So the only way to know if they have an active infection or not is to do testing, which gives you a rapid result. So you test them, it gives you a rapid result. Unfortunately, a lot of these tests are not very sensitive, which means they have false negatives, which means even if you are infected, the test might give a negative result. So you need to combine that testing with strict infection control protocols, which means everyone who's entering a nursing home should be wearing a mask, should be wearing a gown, should be preventing spread of the infection within the nursing home. So I would say that is, in some sense, the top priority. The other is there are some intergenerational households where you have older people living with younger people. So I would focus on those intergenerational households and try to figure out how can we protect the older people in those households. Maybe the younger people in those households need to temporarily move out. We need to provide them some alternate accommodations, or we need to do something else. So that's basically what risk segmentation is, that protecting the older population, protecting the intergenerational households. But for the other households, let them go about with moderate social distancing. They can still go to work. You can wear your masks. You can wash your hands frequently. Because in some sense, the younger population that's the lowest risk getting infected is going to help build herd immunity. It's going to build a shield for the more vulnerable population. And as you said, like, if you have a longer time horizon, everyone's we're like a high fraction of people are going to get infected till the time we hit herd immunity. So we can't focus on just short-term gains. We have to look at this over a 2-year time horizon. So the MIT research said that, look, when you look at economics and mortality at the same time, a strategy which segments risks is a better strategy than a strategy which says everyone is in the same bucket. But ultimately, we will never have, it's still a model. We will never have perfect information. Ultimately, decision makers have to make decisions under uncertainty, right? This is a new disease. Can I say for sure risk segmentation is the best strategy? No, but it seems to fit the basic facts.
Neeraj, one of our other colleagues is a specialist on decision making, and I'm thinking of Professor Abbas. He and I are collaborating right now to try to see if we can focus on the topic of risk, decision making, and leadership, which I think, and governance perhaps, which I think combined is going to be crucial over the next phase of what we're going to be facing going forward, because let's face it, we are living in a new normal. The life prior to January doesn't exist anymore.
Yes.
I think policy people need to understand this, right?
Yes.
I mean, that life does not exist.
Yes.
And the other positive that I can mention, and you feel free to comment on this, we've lived through viruses before. And we've learned to live with them. The most recent one I'm thinking about, it's the AIDS virus, right? The AIDS virus did not stop the world. Yes, it did a lot of damage, but yet we've learned to live with it. Ultimately, we didn't necessarily hide from it. And this is one just like that, right? I mean, we're not going to be able to hide from this. We're going to have to face this, right?
I agree. I think that this virus is here with us for a long time, and we have to learn. I wish we could wish it away. We could say, but we cannot. So in some sense, whenever we think about policies, we cannot have the counterfactual be that there's no COVID. COVID is there with us. We have to figure out, if we don't do this policy, what do we do next? And we have to have this 2-3 year time horizon. So we cannot say that, okay, this is working right now. We cannot be in this state of like stringent lockdown forever. So we have to have that long-term vision to say, what is the best strategy in this case? And we have to be willing to make these decisions under uncertainty that, we might make mistakes. That's the way life is. And then we might course correct and we might change our mind, but that's, in some sense, that's also going to generate evidence for us about what's a good strategy, right? So now when Sweden is implementing a certain strategy, it is helping us figure out whether that strategy works or not, right? So as other states and countries follow different strategies, over time, we will learn from them, which ones were more successful versus not. Will we have a perfect answer from them? No, there's so many things different between Sweden and the UK and the Germany. They're doing so many different things. We will never have a perfect answer. But I think that's where leadership comes in, that you got to look at the facts and you got to make a decision under some uncertainty.
So in the last few minutes that are left to us, I'm going to turn back to Harley. I think there are a few questions more. So Harley?
Hi. All right. So this first question is from our Facebook Live. And it says, a friend has been saying, quote, don't look at case counts, unquote, when trying to grasp the risk of transmission. What indicators are you monitoring with regard to risk?
So his friend is right that case counts are a function of two things. One is the number of people who are infected, and the second is the amount of testing that's going on. So as you increase the amount of testing, you just get more people in the community who are confirmed cases, but that doesn't really mean that the number of confirmed cases or the true extent of the infection is rising over time. A lot of people say looking at deaths is a better indicator of the true extent of infection in a population, because deaths are probably more accurately measured. But now people are even doubting that. That was one of the reasons to do the seroprevalence studies, which is doing antibody testing of the population to figure out the true extent of the infection. So I would probably rely more on deaths and antibody studies than the number of confirmed cases. The other thing is looking at the fraction of people who are positive in your testing. So as you do more testing, what you should find is the fraction who are positive falls down. So you could use that as an indicator of having a more stable infection in your population.
Okay. Another question from Facebook Live. What would you say to a person who interprets what you're saying as permission to forgo masks and resume business as usual? What about an average 50-year-old who wants to avoid getting sick?
So what I'm saying is business as usual is not going to work. COVID is here to stay, and we have to take more precautions. But what I'm saying is, when on the other extreme, very stringent social distancing is also not going to work in the long run. What you need is a middle path. What you need is a policy that works in terms of controlling the extent of infections in the long run, that doesn't overwhelm the healthcare system, and that keeps our economy going at the same time, that keeps our healthcare system going at the same time, that keeps our cities working at the same time. So I think that's what I'm saying is you cannot, either extremes are bad. You cannot have a solution where business as usual and you say you just ignore COVID. On the other hand, you cannot in the long run have a solution where you're just stuck in the stringent lockdown. You need something in the middle. And that's what we should be thinking about. How do we segment risks? How do we do moderate social distancing? How do we kind of balance this trade-off?
Is it possible to have varying levels of lockdowns in the same county? For example, cities that are not as densely populated can move into later phases of reopening before more densely populated cities?
That is certainly possible. The population density could influence how contagious the disease is, how quickly it spreads. So you might want to have a different strategy for different neighborhoods, for different populations, and so on.
Okay. Regarding reopening of schools, do you recommend that students be tested for antibodies?
As I said, I think we should be testing students for antibodies to first figure out how many of them have already had an infection, to figure out how many of them had an infection that was asymptomatic, and to figure out what is the risk that they might transmit the infection to other children, to their teachers. So we really need to understand that transmission of infection within the household, to other children, to other adults. So I would advocate for that, and we are planning on such a study, and hopefully we can implement it over the next few weeks.
Why do the mortality statistics on the CDC's website include deaths caused by COVID-19, pneumonia, and influenza?
You should ask the CDC that that question. So I think those are just some causes of deaths that CDC tracks over time.
Next question is from Facebook Live. Can you give us a couple more examples of risk segmentation?
Sure. So risk segmentation would be looking at nursing homes differently than rest of the population, looking at the elderly population differently, looking at intergenerational households where you have grandparents and kids and grandkids living differently. It could be looking at people in apartment buildings that are more crowded differently than people living in single family homes. So there are a variety of ways in which people's underlying risk might be different. The risk of getting infected, and then second, conditional on getting infected, the risk of having severe health effects.
This next question is from Facebook Live as well. How concerning are the revelations that children could be susceptible to other side effects from COVID, such as the Kawasaki disease? Could this mean children are more vulnerable than we initially thought?
So there is emerging evidence that there are these rare syndromes that look like Kawasaki disease, but people still don't know how prevalent that is going to be among kids, and whether that is related to COVID or that is a new phenomena. So I think right now we just don't have that information. And that's the thing about this disease. There is a lot about this disease that we don't know. And we will have to make decisions about this disease under that uncertainty. To truly understand this disease might take us several years, but we need to make decisions now, not after several years.
Okay. And the last question, it appears that along with social distancing, we are shutting down some medical resources. Example, the Mercury ship not taking any more patients. Won't the medical community be overwhelmed if we have a second wave with a higher peak?
They would be, because what is happening right now is not only do the hospitals not have COVID patients, they're not performing any elective surgeries, so they don't have a lot of other patients. So their finances are under stress, and they might be able to withstand the shock for another 2 months or 3 months, but ultimately the lack of financial resources for hospitals would undermine their capacity to treat patients. And if this epidemic is going to stay with us and we're going to have a second peak that might coincide with the flu season, then it looks very scary, because now we have hospitals that are depleted and we have a simultaneous flu and COVID epidemic. So I think we need to think about those possibilities when we are making decisions right now.
Okay, thank you so much. Yep.
Harley, I just wanted to thank you and Neeraj for sure for coming on and educating certainly our local communities. And I appreciate the partnership with our California Contract Cities Association and all of the mayors and council members that came and will continue to come over the next few weeks. So thank you. Harley, back to you.
Thank you so much. Thank you so much, Frank, and thank you, Neeraj, for joining us. For those of you listening in, thank you so much. Today's talk will be posted onto our website, and we hope you'll join us next week for another Price Talks. Have a good rest of the day.
Thank you.